Good morning and welcome to this year's State of Care report. Welcome in the room and also online. My name is Chris Day. Before I introduce the panel, I just want to explain what we're going to try and do over the next hour. Ian Trenham, our Chief Executive, will talk through some of the key themes from this year's State of Care. And then in the room, you'll have the opportunity to ask questions to explore those themes in more detail. Before I introduce the panel, just a quick bit of housekeeping for those in the room. There was no planned fire evacuation test today, so if you hear the noise, please go towards the green doors. Those of you who need support to leave the building, if you use the front set of green doors, that would be great. Okay, so just to introduce the panel to you, got James Bullion, our Chief Inspector of Adult Social Care and Integrated Care. Got Kate Taroney, our Deputy Chief Executive, and we've got Chris Taziki, who's our Chief Inspector of Mental Health Services. Okay, so let's begin with a quick exploration of the key messages in this year's State of Care report. Ian, over to you.
Thanks, Chris, and good morning, everybody, and an enormous thank you for joining us. We do a long process of briefing the press and stakeholders. This is always the best bit of the conversation for me, because it's about bringing together the people that we work with on a regular basis. And the people in this room and the people online are the people that really understand and really deliver health and social care in this country. So an enormous thank you for coming. And each year we do our State of Care report, and it's our annual report to Parliament. And it tries to summarise all of the things that we've seen through all of our regulatory work, whether that be inspections, whether that be the conversations that we've had with people, or whether it's the information that the people who work in services or the people that use services have given us. And we try and synthesise that through our core purpose, which is to do two things at the same time: to offer the public assurance on the health and care services that they use, and secondly, to take the information and the insight that we derive from our work and encourage care services to improve. And this year, our headline message is really a straightforward one, in the sense that we're building on last year's message. Last year's message was we saw a health and care system which was gridlocked, and it was difficult to move about. And this year, what we're seeing is that the impact of the cost of living crisis, coupled with an escalating challenge around the workforce within health and social care, has meant that there's a real risk of unfair care. And unfair care develops when those that can afford to pay for care do, and those that can't don't. And when they're unable to pay for care, they end up having to wait longer. In many cases, they're unable to access care at all. And in the longer term, they suffer poorer outcomes. But before we get into the detail of the report, I do want to just take the opportunity to recognise the fact that every time we do this report, we always talk about what's going wrong. It's really important to recognise the fantastic work that millions of people do every single day, the people that work in health and care services, as well as the people that volunteer in health and care services. This is a complex set of services that work together really well, and every day there are some brilliant episodes of care. And I think it's important that we acknowledge that. But in terms of some of the core messages, in terms of cost of living, particularly in adult social care, what we're seeing is adult social care providers are facing increasing running costs. Adult social care providers are disproportionately exposed to challenges around fuel and food, but most importantly around wanting to pay their staff a good wage in the context of a rising cost of living. If they can't do that, it has a direct impact on recruitment and retention. And whilst we have seen some decrease in vacancies in adult social care this year, it's dipped below 10% for the first time in a while. That is in large part because of a significant increase in workers from overseas. And the worry that we would have with that is how sustainable is that as a model. But we're still seeing turnover rates that are probably just south of 30%. And profitability within care providers remains historically low. And again, that causes us real concern in terms of the sustainability of adult social care providers. And what difference does that really make, though, to people who are using service? One of the things which I think is key to adult social care services is that relationship between those people who give care and those people that receive care. It's incredibly hard to build a relationship if a third of the people delivering those services keep moving each year. It's incredibly difficult to deliver that continuity of care that we all know is so vital for delivering really high quality care. It also makes it difficult for care providers to make the investments that they need to make in their people, in their infrastructure, and in their technology. We've seen local authority budgets struggling to keep pace with the cost of living, and in turn that means that local authority fees are not keeping pace with inflation, and that of course passes into to providers' running costs. And on a practical level, we know that in some parts of the country, significant numbers of people are paying for their own care. And what we're seeing is examples where people are not able to continue to buy the care at the levels that they have. And in a practical level, that means somebody that was maybe receiving 3 visits a day of domiciliary care are now having to cut down to two visits a day. That impacts on their quality of life. And it also impacts on their family because their family are having to fill in the gaps in many cases. And when we talk about workforce, what we see in the NHS is continuing challenges around workforce in a range of different ways. Obviously, the industrial action has caused the NHS a number of problems, with only a quarter of staff in the NHS saying they're satisfied with their paying conditions, down 12 percentage points from 2 years ago. Staff, whenever we talk to them on inspection, talk about being overworked, exhausted, and stressed. And of course, that's going to impact on the quality of care, their ability to deliver safe and high quality care, the care that they want to deliver. But it is, of course, true to say that workforce challenges predate the current industrial action. The long-term NHS workforce plan is a good thing, and I think we would recognise that as being a potential route out of the current workforce challenges. But it does still need continued focus and continued resourcing, and it isn't a quick fix. But the NHS and social care are two sides of the same coin. And whilst it's great to see an NHS workforce plan, there is still no long-term workforce plan for social care. And we think, again, that is a really important point. And we're hopeful that this year we'll see some progress on a national workforce strategy for social care. When you bring these things together, you do start to run the risk of unfair care. YouGov survey suggested that 8 in 10 of those who used private healthcare last year would previously used the NHS. Other surveys have suggested that people using private care had tried to use NHS care in 56% of cases. That landscape risks exacerbating existing health inequalities and increases this risk of a two-tier system of healthcare developing, with those that can't afford to pay for care waiting longer. And for some, this will, of course, mean further deterioration in their care. When we ran the adult inpatient survey, 41% of people talked to us about their perception that their health had deteriorated. And it's not just their physical health, it's also their mental well-being. The longer you're on a waiting list, the more you deteriorate in a number of different ways. And the box there just calls out what this really means in practice. We talked to a person who was on benefits. They'd attempted to deal with their own oral health matters. That didn't go well. They ended up going to a private dentist and had to pay £1,200 for care. They put that on a credit card, and then that has a significant impact on their household budget. There are many of those different sorts of stories that are around today. And there are two particular areas service areas that we highlight in our report: maternity and mental health. And in maternity services, what we found is again poor care in a number of areas. We've been carrying out a focused programme of inspections in maternity to give us the most up-to-date picture of maternity services in a post-COVID world. Whilst there's been some good evidence of good practice, we've seen things like some of Donna Ockenden's recommendations around consultant cover now being widely adopted. We do think even that has a fragility to it, with some trusts really struggling to maintain their aspirations around consultant cover. We've seen difficulties with governance and lack of oversight, and a presence, sometimes a leadership presence, in a number of trusts really lacking. And we've seen continued difficulties in working relationships and poor communications, and oftentimes women not being listened to. This recurring theme of women not being listened to, whether that's when they first arrive in a maternity service, whether that's in the antenatal or postnatal care, they're not being listened to. When we've done work on safety and leadership in particular, we've seen 15% of services rated as inadequate for safety, and 12% of services rated as inadequate for well-led. And when we look at our overall service ratings for maternity care, only half of them are rated good good overall at a service level. And again, we've seen real challenges for women from ethnic minorities. Again, we've seen ethnic minority groups just simply not getting the same experience of maternity care as white women do, with significantly higher risks around birth, both prenatally and postnatally. And we sought to try and understand why that was. And we've got an ongoing piece of work, and the first part of it we feature in the report, where we spent some time with some ethnic minority midwives to understand directly from them what it feels like to work in these services and to offer care to women from ethnic minorities. They talked about racial stereotypes. They talked about lack of cultural awareness among staff. And there's a number of direct quotes from that work in the report. And they make really difficult reading, and they definitely cause us pause for thought, I think. And one of the quotes, which I think probably summarizes the issue, is this: the NHS is amazing, but it was built by white people for white people. We need to adapt because now we have a diverse population and workforce. And when we look at ratings overall, what we talked about last year was some of the worst ratings we'd seen in the maternity core service since we started looking at it as a core service in 2018. And those ratings have got slightly worse this year. And let's move on to mental health. We've got concerns in two areas in mental health. The first one is access to care, and the second one is quality of care, particularly around inpatient mental health services. We talked last year about the real struggle that many people have accessing community mental health services. And on a very pragmatic basis, if people cannot access care in the community, they go into mental health crisis and they go to the one place which is open, which is usually an emergency department. We spoke to one trust that talked about having 42 mental health patients waiting for over 36 hours in the emergency department in 1 month alone. And obviously, an emergency department is clearly not the place to be looking after a person in mental health crisis, even if they have some physical needs as well. And the quality of care, once people do get a bed in an inpatient setting, is not good enough. 40% of providers are rated as requires improvement or inadequate in the safety domain. And when we've looked at this, I think what we conclude is recruitment and retention of staff remains one of the biggest challenges. 1 in 5 mental health nursing posts remain vacant. That means they're covered by locum staff and agency staff. And as in social care, mental health services, mental health inpatient services rely on a relationship between carer and the person being cared for. And it's so difficult to maintain and sustain that relationship with a high turnover of staff. But what we've also seen and spoken out quite clearly about is real concerns about increasing uses of restraint and restrictive practice. Restrictive practice where people are spending very significant parts of their day locked in their rooms. And concerns about violence and other forms of restraint. And I think we agree with many care providers that restraint and restrictive practice is a failure of care. It's as simple as that. And we all have an aspiration to reduce that to the absolute minimum. So how do we navigate our way out of all of this? We think there's an opportunity presented by systems. The advent of ICSs this year in particular, in the last 18 months or so in particular, we think represents an opportunity. We think there's an opportunity for ICSs and local authorities to be louder and clearer about addressing inequalities in their area. We worry that if the plans that ICSs have currently got in place do not solidify around some solid goals and some solid resourcing, there's a real danger that the inequalities that already exist continue. And we also need to recognise that the important role that family carers play and unpaid carers play and volunteers play in the places in which people live. They often act as the glue that brings together paid-for services. We began our pilot work on integrated care systems and assurance work with local authorities this year. And next year, when we stand on this stage, we hope to talk to you in a lot more detail about some of the findings of that work. So what is the way to fairer care? I think it is fair to say that we've seen staff and leaders working incredibly hard this year in really challenging conditions. I want to pay tribute in particular to leaders in the NHS who've had to cope with significant strike action, constantly reorganising their services to make sure that they continue, on top of the existing pressures that were already there. But we really want to see three things. Local systems need clear and realistic goals, particularly around inequities in outcomes, to make sure that we can bake in fair care for everybody in each place. We need a national workforce strategy for social care, one that raises the status of the workforce, ensures that career progression, pay and reward attract and retain the right people in the right numbers, in the right place. But all of this needs to be underpinned by a long-term sustainable funding solution for adult social care. And finally, there must be renewed focus on leadership and culture. Leadership and culture comes up again and again when we look in any of these services, but particularly in mental health and particularly in maternity. The challenges described in this year's State of Care are to some extent legacy ones, a lack of joined-up planning, investment and delivery of care. Integrated care systems do present an opportunity of bringing together local health and care leaders with the populations that they support to understand better, to plan and to deliver care at a local level. This opportunity must be grasped to ensure fairer care for everyone, so people can get the care they need, not just the care that they can afford. Thank you all for coming. That is the State of Care 2022-23. Thank you.
Thank you, Ian. As you can see, such a wide variety of topics that State of Care covers each year. So just before we begin questions, just to call out the spare chair at the end. Unfortunately, our colleague Sean O'Kelly is unwell today, so can't make today's briefing. In terms of questions, for those of you in the room, if you just raise your hand in a normal way, if you could say who you are, your name, and also if you represent an organisation, which organisation it is, that would be really helpful. But the floor is yours. Ask questions away. I don't know, as those of you familiar with State of Care, this is a familiar occurrence, so over to you.
Thank you, Chris, really, and thank you to everyone in the Care Quality Commission again. You're passing out the thanks to other people. Let's put it back to you, really, so thank you, Chris. It's really good to see in the State of Care report that explicit section, not an explicit line or a paragraph on our health inequalities. I think that's a statement from CQC on going forward. So my question now, my question is, what role does the Care Quality Commission see as having in regard to the planned review of the 42 integrated care systems, care boards, and, this is a key, the national guidance, right care, right person, looking at how the police work with partners in responding to mental health incidents? Thank you.
Thank you, Brendan, for keeping that tradition alive. James, I wonder if you could start with that question and maybe pass on to you, Chris.
Yeah, thanks very much. So, as Ian said, we really see a big opportunity for looking at how integrated care systems get a grippy plan and get local leadership to try and address the issues that we've outlined in the state of care on inequalities, on workforce, but particularly how they demonstrate local planning and local involvement of people in the way that they're working. So when we're looking in our systems reviews, we're looking at 3 areas: leadership, quality and integration. In the leadership expectations that we have in our assurance mechanism, part of that is a commitment to co-production and a real demonstration of how local need and local people are influencing not just involvement but actual influencing of the plans. And in the 2 pilots that we've done for ICSs, we've designed in an independent conversation with local people, local co-production groups to test out whether that's happening. And in the 5 assurance pilots in local government for adult social care, we've done the same thing, and it's really proved very effective in those 5. We've had meetings with nobody else in the room, just testing out what do people really feel and what's the real experience of people in the way that services are being provided or designed. And crucially, when we rate or score or judge, our new way of working, our a framework for assessment, puts a really heavy emphasis on people's views, co-production, and looking at it from the bottom up, as it were. And that's generated a huge amount of interest out there in local government and in the NHS on switching to work in that sort of way. Thank you.
Thanks, James. And Chris, on the police matter.
Thanks, Chris, and thanks, James. And I think one most important point that James mentioned is around leadership. And Brent, as you mentioned, in terms of integrated care systems, the opportunity of having ICSs and their leadership in bringing all the stakeholders in one place to discuss about, the services that are provided, and looking at the pathways for people who need mental health services. Because we know right care, right person, it's about bringing systems together to think about the pathways. Police have got a role to play. And I think systems need to bring police on the table to talk about their interventions, especially when their need in terms of risk management, in terms of, because we are going to have moments where, unfortunately, we're going to have people committing crime, unfortunately. We're going to have people maybe presenting a high risk that sometimes mental health services staff might not be able to safely respond in a holistic and appropriate way, that they will need the involvement of police. But it's about system understanding. When do we need police to come in? By thinking about people's human rights, thinking about people's holistic care, and then that approach as a system coming together and understanding those pathways will be critical, I think, for ICSs.
Thanks, Chris. Next question. Who are you get the mic to? I think it was that gentleman was first.
Thank you very much. I'm Jonathan Senker from Voiceability. Really good to get the opportunity to read the report, or at least read it this morning. And it was great to see the really strong focus on the lives of the 300,000 people each year that are, for whom there are applications to deprive them of their liberty. And this, it's a huge number of people. It's about the size of the population of Doncaster. And as the report makes really clear, some of those people will live and die in settings that are more restrictive than necessary. And the government itself has said that the situation potentially places people at risk of being unlawfully deprived of their liberty, and then took the decision not to act to reform a system that it itself has says doesn't work. It was really good to see the CQC's concentration on this, and that you're going to be picking it up further in applying your new methodology. I'm just wondering, in this circumstance, where we have a system that's not working, that's unlawfully depriving people of their liberty in a way that has real effects on their lives, what will you be looking for in terms of what can good practice look like in this environment?
Really good question. I think one for Chris, but just to say that what the report tries to do each year is to describe what's working well and where we want people to go, as well as where we're going to take action restrict and reduce services. But Chris, do you want to provide that first?
Yeah, I mean, thank you for the question. It's a really helpful reflection. I mean, the main goal really is to think about a less restrictive environment. That's where we need to see people in. You know, yes, there are moments where people might need to be in hospital, but it's thinking about how safe people are when they're in hospital and thinking about the quality of care in hospital. I mean, in our report, I think we reflect on people with a learning disability and autistic people. You know, there's been a call to make sure people actually end up being in community provision, which is appropriate to meet their needs. In the report, I think we talk about more than just over 2,000 people remain in hospital, especially people with a learning disability and autistic people. And half of that, just over half of that, have been in hospital for 2 or more years. Yeah. So there's something about thinking, especially when we're talking about the leadership of systems in terms of actually thinking about why do we still see more people in restrictive places. Sometimes it's because we don't have appropriate services in the community. So it's thinking about that whole pathway about what do we need to see in the community in order for people then to be discharged from hospitals and go and live their life in the community. Because the challenge sometimes is if you don't have those appropriate services, people end up in the community and immediately come back again into hospital services and then staying in hospital services for a longer period. So there's so much work, I think, which needs to happen in just reflecting about actually how do we support people to be discharged and end up living in less restrictive places.
Do you want to say anything else additional?
Yeah. Just to build on what Chris says about seclusion and restraint, I think we do say in the reports in relation to deprivation of liberty and the liberty protection safeguards that only 20% of those 300,000 are compliant with the rules. So therefore, as you say in the question, that would imply the system simply isn't working. And I think this year has been the first year when we have officially, as it were, raised our concern at national level about that system and the delays in the implementation of the new ways of working. I think when we go and look at systems in assurance terms, we will expect to see really well managed risk-based dealing with the people who have got an application for liberty, for deprivation of liberty, and we'll expect to see those outcomes protected in the support plans or the health plans that people have got. But we are working within the constraint of waiting for reform in that area. So we recognise that we can't, and it's very difficult to mitigate the risk completely. Thank you.
Thanks, James. Next question, I think you've... Yeah. And we'll come to you next.
Hi, I'm Rachel Power from the Patients Association. Ian and team, thanks a million for preparing this report, but it makes for grim reading. And I suppose for me, time and time again, we hear that the most vulnerable in our society are being failed. And it feels to me that we're, not the people in this room, because we're here because we don't want that to happen, but it feels like that we're normalising the unnormal with patients and family members and the most vulnerable. You know, we go back to Marmot Review. How do we take action now to stop this absolute decline in the most vulnerable? You know, a kind society does not treat our vulnerable like this.
Thanks very much, Rachel. I think we'll perhaps talk to Ian in a second, but I think that one of the issues to me is continuing to raise this as an abnormal thing and not to expect. I think when people start to normalise poor care, we're in a situation which is...
And notwithstanding the horrificness that's going on in our world at the moment, I woke up this morning and looked around and this isn't being covered. And once again, we're seeing, you know, reports coming out that are not good enough, not being covered because we are normalising it.
Yeah, we're going to, I mean, we'll come, maybe talk I don't disagree with you. I think had I known there was going to be a problem with 2 by-elections, we plan this about a year in advance, and we don't plan for the idea of by-elections or indeed international wars. But yeah, but I think you're right. I think the key thing about this is just, I'll hand over to Ian in a second, but this isn't just a day for me. These are ongoing messages and ongoing campaigns, and there's an important message here that we will raise both with local leaders and national leaders. But I think we can't accept poor care. We can't normalise poor care in a way that some parts of the system potentially are beginning to do. But Ian, I don't know if you wanted to talk to that particularly.
I mean, I think as Chris said, we absolutely are not normalising it, and really from our point of view, this today represents the start of a campaign, and we do this each year were, although there's a bit of a ta-da moment as we release the report, the reality is we talk about the report repeatedly with parliamentarians, with other groups. On a daily basis, we carry out our inspection work, and again, we make sure that from a media point of view that is well circulated. But I think also the thing that is probably different this year, which is difficult to see at this point, maybe we'll be a bit clearer next year, is we've taken on the largest extension of our powers in a decade in terms of looking at ICSs and local authority assurance. And I think, you know, we've talked in the past about often people's experience of care is as much about the way they transit between individual providers as it is about the individual care in an individual provider, if that makes sense. So an ability to look at both of those things at the same time, which we now have, I think is going to be potentially very powerful. And so in the reference we made today about inequalities and seeing ICSs as a lever to fix, and I use that term advisedly, but fix inequalities or at least address them head on, I think is something new. I think it is something different. And so, you know, we're very clear that this is a work in progress, and we are up for it, and we're determined to make a difference. Thank you.
Thanks. I think one then and one difference, just those two. The lady. I wouldn't. Yeah. Okay.
Thank you. Ruth French, Director of the Outstanding Society and of Stowe Healthcare. When we look at the ratings appendix at the back, you'd be forgiven for thinking that the picture hasn't changed hugely in adult social care, but that doesn't really align with what I'm looking at every month in terms of inspections. So are those ratings masked by the fact that far fewer inspections have been happening, but of those inspections that have been happening, a far greater number are RI or inadequate in adult social care? Because when I looked at the data for last month and did the sums myself, it was about 41% were RI and inadequate. Thank you.
Thank you. I'll hand over to James in a second. One of the things that's interesting about the data is the data itself masks organisations that have left the market as well. And you think about people's experience of care isn't just the ratings of individual organisations, it's a lack of access to care in the first instance, particularly domiciliary care, but also residential nursing care. So I think there's an important, which is why we don't solely focus on just the ratings themselves, because people's experience of care is have I been able to get access to care? Has that care been good? What's the transition between adult social care and dentistry, or adult social care and secondary care? And I think that the holistic picture will probably pick up more and more as we do local authority and ICS work. But James, sorry, I may have stolen quite a lot of your thunder, I don't know.
No, it's okay, I'll just build on that, Chris. I mean, as Chris says, there are two issues at play here. One is the formal inspections and the outcomes of those, and they are overall roughly similar, but they are still mixed across the country as you look at them. And then secondly, because our work is a mixture of risk-based inspections plus interactions with providers, so many thousands of those in addition to the inspections that we do, actually the picture is more complex than just a rating. And Chris's point about the access issues, that's where the unfairness is becoming built into or baked into the social care system. So not only do we have the issues of the pace of reform and the means test question not being addressed since 2010, but now we see in the period covered by this report 2 million requests for care, but yet less than half of them being met by the state system, and actually a reduction in state-based home support. So the experience of those individuals is actually a complete lack of quality, because they're not getting their needs met effectively. So I think today's report tries to broaden out from, as it were, the regulatory outcome, which we still place a great deal of focus on, and our new framework will make us lighter of foot and be able to intervene quicker, as it were, to push that quality in the right direction. But without structural reform that we're calling for, i.e. the funding and particularly the workforce strategy for social care, is underpinning a lot of the outcomes for quality, because staff find themselves stressed, not enough of them, and that's impacting on the way that they do their jobs. So really, I'm sorry to broaden it, but I do understand the technical point you're making around if you just look at the figures, it doesn't look too bad, but actually the experiential point for family carers, for people receiving care, and indeed for providers is much worse than that.
Thank you. Come to the front and then to the middle.
Hi, Andrea Sutcliffe, the Chief Executive and Registrar of the Nursing and Midwifery Council. Thank you very much, Chris, Ian and the panel for the report and the work that's gone into it. It's obviously some very sobering issues are raised in the report, but I was glad to see that you reminding us that people get out of bed every day to try and do a good job, and they are trying very hard to make a difference and deliver good care. As the regulator for the biggest professional group that spends the most time with people using health and care services, not surprising that there's lots of critical issues in this report that impact on our professionals. So increasing recruitment and retention, and I would include in that securing more and more diverse clinical placements for students, tackling discrimination and racism, providing support for continuing professional development, improving maternity services, improving mental health services, and the fact that we haven't got a workforce strategy for social care. Although, Una, I know that you're going to sort that. I agree with you, Ian, that integrated systems should provide a solution, but they're going to need to be held to account to prioritise these issues. So how's the CQC going to make sure that that happens using your new powers? Thank you.
Thanks so much, Andrea. I think there's a number of issues there that have been picked up as the legislation was laid, and I think there's a real interesting point about where we've got to now in terms of where the priorities sit across different groups. I wonder if, James, you picked up leading the work, and then if other colleagues want to join in.
Yeah, so, I mean, listening to your description there, Andrea, where do you start, as it were, in terms of what do you single out to be the emphasis that you put on the way that we look at systems to see how the local improvement agenda is laid out? We're clearly putting an emphasis in the initial work that we're doing around equalities and dealing with inequalities, and that's both the unwarranted variation type of outcomes for population, but also the cultural and leadership issues that come with trying to change the way that we are tackling discrimination or tackling the unfairness in the local system. So we're putting a great deal of emphasis on that. And sort of underpinning that, I suppose, in looking at the quality and safety in the way that systems are working, the interactions between the provider work that we do and the systems leadership, we're trying to also bring that lens to make sure there is a definite improvement plan in place. But it's the beginning of a journey. I mean, it's going to take us a couple of years as a regulator to get round the system, but we're trying to, in this report, send some very strong signals about work needing to begin now right across England in those ICSs.
Thank you. We'll go to the middle and we'll go to the back. Yeah.
Hello everyone, I'm Julian Butt from the Race Equality Foundation. Obviously would echo concerns of many people here about what the report shows, particularly what it tells us about living in Britain today, and I continue to be shocked that perhaps it's not getting the attention that it should do. But I think particularly worrying for me was what the report reveals around modern-day slavery. And I do wonder whether, in your suggestion about a national workforce strategy, what opportunity or what likelihood that's going to have on impacting on that. Because I think without a specific focus on this, we're actually going to see the current situation getting worse, not better.
Do you want to cover it first, and James, you might want to follow up as well?
Yeah, thank you. I mean, I think you will have seen in all of our media work, both last year and this year, a focus on outcomes for ethnic minority women in maternity. And what was quite striking, you probably heard me say this last year, that on all of my pre-recorded interviews last year, all the references to poor outcomes for ethnic minority women were clipped out. This year, that is not the case. We have had very strong coverage of our messages around poorer outcomes for ethnic minority women. that's a small thing in one level, but it means I think that the dialogue is perhaps slightly broadening out, more broader than where it was. In terms of the modern slavery point we've made in the report, I think we have to see that in context. There are 1.5 million workers in adult social care, and we've seen 37 instances of modern slavery that we've reported to other agencies. That's straightforward criminality, and let's be really clear about that. When we see that happening, we will absolutely act on it, and we will report it to other agencies. It is a 4 times increase on last year, so it remains a significant issue, and it remains an issue that our teams are looking out for. As part of our work, we look very carefully at how recruitment happens in individual providers, and we look in some detail to make sure people are properly trained, people are properly referenced, and that reputable organisations are used in recruitment. And I take that issue incredibly seriously.
Do you want to add into that, James?
Well, only to say, as Ian says around the modern slavery, that's one particular issue, but we want to send a strong signal that as the information from colleagues in Skills for Care says, actually diversity created by international recruitment is a positive, both for nursing and for social care. And we do not want to send a sort of message that doesn't value those people. Actually, we begin with the positives and valuing with them. But to pick up the broader point you make about the workforce issue, I mean, we see it as a positive step for colleagues in Skills for Care to have stepped into that space on behalf of the sector, and look forward to playing a part in that process. But we do feel that the workforce issue, international recruitment is one part of it. There are several other parts that are to do with the deal between providers and workers around training and wages and development. And those parts of the elements of the workforce approach need to be addressed. And in that context, modern slavery is just one aspect, a very important one, but we want to send a very positive signal about the contribution made, particularly in social care, about the additional staff working. Thanks.
Okay, come at the back, we'll go that side and then that side, yeah.
Thanks, Chris. William Petts, I'm Head of Policy for Healthwatch England. So we've welcomed this really important report, so thank you for it and for the presentation today, and also for our opportunity to feed into the report. Ian, when you looked at the opportunities, you focused on joined up care, which I think is absolutely right. But I know from your roughly 150-page report that there's only 5 fairly brief references to prevention. Now, we've been giving lip service to prevention for decades, but we're very much still a national sickness service than a national health service. So my question is kind of twofold. One is, where are we doing prevention well in care? Are there any areas that kind of show us the way in terms of a preventative approach and what can be achieved to ease pressure on services? And secondly, what is the CQC doing to try and incentivise prevention across services over the coming years?
I think, before answering, one of the issues that be really important extensions of our powers is to look at the role of ICSs, and ICSs themselves have a role both in supporting delivery and indeed in prevention. So I think that will give us an increased understanding. State of Care is written as it's not a polemic report, it's based on fact and evidence from what we've gathered, and I think the exploration of ICSs will give us that ability. But Ian?
Yeah, I guess to build on that, really I suppose the short answer to your question will be I don't know yet. And I think the ICS work will give us the data sources to look at who's doing what well. Our core work ultimately is about looking at individual providers, and it's difficult to make a good prevention argument at an individual provider level, as you probably appreciate. I think there are people in the room who are running other agencies who I know are, we're starting to talk as a collection of arm's length bodies as to what more we can do to promote prevention more broadly. So I think the conversation is there, but I share your sort of your unsaid concern, I suppose, that prevention is not yet where it could be.
Okay, there's 2, and further back, we'll go. say former colleagues, so we,
Good morning. I'm Rosie Bennyworth from the Health Services Safety Investigation Body. And firstly, thank you for the report, an excellent report, and as many of others have said, sobering reading. A comment and a question. The first comment is, I think we're all worried about the state of maternity services in the country, and again, sobering reading what you've highlighted. I think there's a huge opportunity with the Maternity and Newborn Safety Investigation Programme having moved to the CQC to really kind of continue that important focus. So I think I'm looking forward to seeing how that develops. My second question, which is probably of no surprise to the panel, is about primary care. As we know, 93% of healthcare happens in primary care in this country, and I was reading the report. I can see that the ratings have changed a little, but not significantly, and I know from many comments speaking to people with the demands on general practice, there's huge concerns about the kind of fragility of general practice, and dentistry is another area it was good to see highlighted in the report. So it would be good to get the panel's reflection on where the state of primary care is at the moment and hear more about that. Thank you.
Well, if I just, so Kate, just to talk a little bit about the work we're doing in maternity and the work we've done, if that's okay, then perhaps I'll come to you, Ian, to talk a little bit about primary care.
Yeah. Thank you, Rosie. So it's a major focus of our report this year, and a comment from the colleague earlier about are we as a country kind of resigned to poorer outcomes for certain groups of people? We absolutely need to not be. So the focus in this report obviously talks about how safety in maternity, 65% of services are inadequate or requires improvement. It focuses on the fact that we know that black mums and Asian mums have poorer outcomes for themselves and for their babies. And then it looks at what underlies that. So the work we did with the ethnic minority midwives, the kind of that Ian talked about in the presentation, the focus on lack of kind of cultural understanding within those settings, how midwives themselves may experience discrimination, and an inability of consistently listening to women, but particularly black and Asian women. And actually, we also did an inpatient survey this year where we spoke to 63,000 patients. And if you're a patient of an ethnic minority background, you're 2.5 times more likely to say that the clinicians didn't engage you or speak to you well when talking about your care and treatment. So it's been a big focus of our work. We will continue to do this inspection programme because we've got to see the dial change when it comes to safety within maternity settings. But we continue to need to challenge and shout about the fact that some people get poorer outcomes if they're from ethnic minority backgrounds, and that cannot be acceptable in this time.
And Ian, just on primary care.
Yeah, on the primary care point, I think there's a couple of things to say there. I think there's an issue here about the quality of care, and I think it's fair to say that the quality of care in primary care and in dentistry is generally good. The issue is one of access, really, and I think this is where we see the integrated care system playing a big part. We've deliberately chosen examples from primary care and particularly from dentistry to try and bring that out in the report. And I think I'm expecting that over the next year we'll be able to talk a bit more authoritatively about the actual impacts of primary care on a system. My concern is that as waiting lists get longer, we know that GPs are often the people who are maintaining people on a waiting list. The idea that someone is on a waiting list and doesn't require care is we all know is wrong. And each of those people on that, each of those 7 million plus people on a waiting list need some sort of support from GP. So we know there's a lot of demand going into the GP sector just simply because of the length of the waiting list. So again, finding data that can articulate that hypothesis, I think, is our task for the next year.
There's two just close to each other at the back, at the end. We'll get to everybody, I promise.
Hi, Helen Wildwell from Care Rights UK. We support people who need care, and I remember sitting here last year, I think I might even be in exactly the same seat, sitting here last year thinking it's pretty bad, it's bad already, and then now it seems to be even worse, if that's possible. And we hear every day that the impact that's having on people's lives as people relying on services are not getting the support they need, people who are getting poor care, the impact that's having on them, their quality of life, their basic rights like dignity and safety, as well as their family carers, their relatives and friends who are expected to kind of step in and fill the gaps, or just powerlessly witness the poor care they're receiving, unable to do anything about it. And, you know, my colleagues who have worked in the sector for 20 years, they've never seen it so bad. And I think there are two things missing from this report. The voices of those people who are really suffering, really struggling at the moment. And the second thing is CQC's role. And with things so bad, this is the time when people need their regulator the most. And what we hear is a lack of action from CQC. We've seen a drop in inspections, 2/3, according to one FOI report earlier this year. And a lack of urgency about how we're going to deal with this. Because as Rachel said, we cannot just leave people in really vulnerable situations to just struggle on and have their basic rights being breached in front of our eyes.
That's a good question. I think it's fair to say this year, perhaps meant more than most, we've taken more regulatory action in more difficult situations than others. But your point is well made around the difference that made. James, I wonder whether that's something you can talk about in context of particularly adult social care.
Yeah, I mean, I think it's a really good question, Helen. And in a sense, as the regulator, it's our job, isn't it, to state what we see and to advocate on what we see. And that's what we're doing in the State of Care report. It is up to all of us, including us, to have those conversations with those that are overseeing the delivery of social care and NHS services to make sure that they see what we see and that there are plans to try and address that and have an improvement agenda. It is, I mean, as a regulator, we point that out. It is the job of advocates such as yourself and other rights-based organisations to make sure there is always a route for people to escalate what they have as an experience so that we can address those situations. So, as Chris says, where that comes to us and we've got the power to do that, we'll do that through our enforcement work. Where we also have a role is with that strategic work, particularly with local authority assurance. Now, I think we are pleased to be back there as a regulator for the first time in, I think, 12 years, having direct conversations with local authorities. The evidence is that in the work that we've done as pilot areas that people are on their tippy toes a bit, thinking actually there is now some national scrutiny of those kind of issues that you're describing about the experience of people, their rights and what action is taken locally to deal with them. I think it's a really hard question to answer easily, but we are allies on the rights-based points that you've raised in making a statement about what people are experiencing and then expecting improvement plans to take place as a result.
One more at the front, and we'll go to the front. So one of the gentlemen directly behind.
Thank you very much. My name is Philip Batte. I represent the Independent Doctors Federation, that is doctors working in private practice. As a statement, the Independent Doctors Federation really wants a healthy, thriving NHS, and we'd rather people choose independent practice based on their own decisions rather than the current situation, just as a point of fact. A couple of points really. Thanks for all the excellent work you do. At this event last year, I asked a question about equality and diversity, and I'm really pleased that there's a greater emphasis on the health needs and the issues that's raised. So thank you very much for that, and I applaud you for that. You say that you should hold people accountable. And my sense was there was a bit of a sharp intake of breath before you used the word gridlocked in the report last year, because you sort of were tentative about that. You talk now in the report of the risk of unfair care. Unfair care is happening. It's not a risk. And what I would say is, have you just sort of bottled it in the phrase? Have you just been a little bit politic by using the risk rather than just saying unfair care is happening?
What I can say generally is that I think we, as I said before, we try to be really evidence-based in what we say, and we try to represent the whole of England. It didn't feel that way when we were having conversations with colleagues elsewhere in national organisations that we bottled anything. But Ian, I don't know if you want to Is there anything you want to say about that particularly?
I mean, I think the point I made is that there are episodes of really good care. Some people get really good care, and some people don't, and it does depend in some respects where you live. There's an element of that in all of this. So, you know, I think we of course could debate the language we've used, but I think our message is clear. I think we are very clear that there's a real danger that a two-tier system becomes embedded. I think what we're warning is that there is an opportunity perhaps to course correct, but it does need everybody to lean into this and make sure that it doesn't happen.
At the front, some more at the front. We've probably got about time for another 4 or 5.
Thank you. George Fielding. I've come from Voluntary Matters, but I set up a social care provider in 2017, so this is, I guess, home territory. May I ask two quick related questions? And sorry if I've missed the first in the report. Of the inspections you've carried out, what percentage of social care providers and homes have you actually closed for poor performance? I guess I say that because my worry is that there's such a lack of supply of new and good provision that I worry that you as a regulator don't have the ability to actually close what is poor performance, which we can't stand for kind of rights-based reasons. And connected to that, and believe me, it is connected. We've heard an awful lot about, how frankly dreadful the situation is, and that it's not because of the people in this room at all. There's an awful lot of people in care and working in care that give their lives to it, including hopefully myself. But what's the aspiration? What's the dream? What's the dream for the CQC? And how in 10 years' time, if I came back in this room in 10 years' time, how would you know we're getting closer to that dream? Because if the CQC don't invest in long-term strategy and giving people that dream, who's going to? So, the positive dream.
Super. Two important questions. I'll come to James in a second. Unless James has that figure off the top of his head, I think what I would say is that the act of closing a care home is moving people out of their home on a ground basis. So it's never something that's taken lightly. And normally we would try and put a package of measures in and support through ourselves and the local authority to ensure that a care home can remain open and active. But we do take action to where we absolutely need to. So James, if you can talk to that, and there's your second point about the action. I think I'll maybe talk to Ian and James again. What I would say is that if you looked at every ICS's 5-year plan, if they delivered the ambition that's set out in their 5-year plan, we would be in a much better position where care was based upon people's needs, responding to local commitments. I think the challenge is how do we collectively make sure and hold providers and those in positions of power at a local level to account for the plans that they've set out, and also how do we prevent, which I probably is part of Andrea's question, a sort of a move back to a sort of central view of how care should and could be delivered. But James.
Well, just to build on what you've said, Chris, I don't have the figure in my head about how many registrations we've withdrawn from care homes specifically, as it were. So, but I want to re-emphasise the point that our approach is one of improvement and learning. So we expect to write our inspection reports with an expectation that providers will try to improve and respond to those. And our partnership, particularly with local authorities in that situation, is particularly key, isn't it? Because of the issues that Chris describes around, that means essentially, every decision on care is a decision on where you live. So, if you've got to move home because of a quality issue, that's pretty serious. So we try to minimise that as much as we can.
I think just in terms of your dream point, I think we've got a strategy. We talk about regulating through the eyes of people that use services. We talk about safety, and we talk about inequalities, to name but some of the things that are in it. And I think for me, if you were to ask me the sort of 10-year question, it would be, the majority of services being good or outstanding, that are organised around the needs, are genuinely organised around the needs of people, and that they are universally safe. And you can walk into any care service and be very confident that it's safe and well run. And it's run in a way that's consistent with the needs of the people of that area, wherever that area is. So, but I think, to build on James's point, one of the things that is important, one of the things I talked about right at the top of the presentation was, our role is not just to assess services, it is also to promote improvement. And we do that on a sort of, on a big basis through things like these sorts of presentations, but we do it on a day-to-day basis when our inspectors are in a home. They are trying desperately to keep the place open if they can, because, as James described, it's hugely disruptive if we have to close a place. But I know that a couple of times a week I'm seeing care homes close down, either because we've closed them directly or because they've chosen to close themselves down because of the action that we are about to take. And I don't think anyone takes any pleasure in that. But the fact that we are prepared to do it, I think, does have a positive effect right across the rest of the sector, because people do realise that we're prepared to take action.
2 or 3 more questions. Just to say, there's a second part to this event today, which is downstairs with more coffee and drinks that Kate's leading, which is a sort of a bit more of an explanation rather than just doing a Q&A, a wider conversation. So if you haven't come to your question, we'll try and do it there. But the lady at the back and then the lady at the front, 2 ladies at the front.
Thank you. Nicola Ranger, Chief Nurse at the Royal College of Nursing. Thank you for the report. I think at this level, really, really helpful to really show the dire state of care. Prior to coming to the Royal College of Nursing, I've been a Chief Nurse at Acute Trust for 10 years and was part of Frimley Health, which was the first trust to get outstanding with the CQC. But I have to say, over the past 10 years, the quality of inspection, and I always felt I was reviewed by my peers, I think the quality of inspection is going down, actually, and we talk a lot. It's very helpful to have this data at this level, but of course these are individual organisations, and individual organisations are made up of people who work very hard, and many of their challenges are outside of their control. And I listen to the language, hold to account, compliance. It's very punitive. In a time where there is a real challenge with recruitment and retention, workforce being the biggest issue, is there a danger when I hear a very punitive language from the CQC that you become part of the problem rather than the solution for the workforce?
The question, we're obviously moving to a new single assessment framework, which I think balances different views together, and part of our role is always to triangulate what we hear from different sources. But Ian, I don't know if you want to talk to that.
And as you know, we're in the process of evolving our regulatory method to a new single assessment framework, which I think may address some of the things you've described. But I do think we do need to recognise that part of our job is to speak up for the public, and we do spend a lot of time trying to balance the needs of the people that work in services, particularly services that are under extreme pressure, as I said in my presentation. But I also need to recognise the needs of the public, and the public will hold us to account for holding services to account, if that makes sense. And so, we try to continually balance that, and sometimes we get it right, sometimes we don't. I know there's been a conversation, a lot of conversations recently with NHS trusts around how we contextualise the reports that we do, but the danger of doing that, or the difficulty of doing that in practical terms, is how do you contextualise? How do you simply say that safety is different in the northeast of England and the southeast of England? And you get into those sorts of conversations, which is something we give a lot of thought to, and we try and work our way through. But I do think we need to recognise that sort of tension between looking after the people that work in services and looking after the public. And if we have to make a choice, it will probably be the public rather than the people who work in services, I think.
So 2 questions at the front, I think, probably to close out for this section.
Hi, Una Smith, Chief Executive of Skills for Care. I was really pleased to see a focus on people working in adult social care in the report. For loads of reasons, they do a really important role for individuals drawing on care and support, but also it's a huge workforce, 5% of the total workforce in England. It's really, really important, and and that's growing, and should be a really positive story. You know, these are opportunities for hundreds of thousands of people to work in fantastic roles. Skills for Care, it's been referred to a few times today, have announced that we'll lead with partners the development of a workforce strategy in adult social care. And I'm quite interested in each panel member's view of what you would like to see in that strategy, drawing on the evidence from the report today.
Probably want to start with James, if that's okay, James.
Thanks, Ona. So I think, first of all, the strategy needs to show recognition, as it were, of a consensus about what are some of the underlying causes, but also the incentives for the way out of the situation that we're in. So there's issues about what attracts people to come and work in social care or in integrated settings as well, which I think is incredibly important. So I'd like to see those kind of issues. And also, I suppose I would like to see a route out of the strategy into policy, whether that's policy implications for organisations like ourselves as a regulator, or whether it's national policy as a response. If I have an early anxiety about it, or an early approach that we might take in from CQC, it's that we might build a sector description, which is absolutely brilliant, but not have a home for the outcome. So I think an early conversation. But I'm sure the leadership skills in Skills for Care, I'm sure we'll have clocked that and be directing that to where it needs to go nationally. Thank you.
Any other colleagues? I've got one, but any other colleagues with a view? Go on.
Yeah, I mean, I think for me, two things really for me. I think there's something about when people experience care, you know, they move from one place to another, and people just want to experience care. So for me, there's something about the link with the NHS workforce strategy, that actually there is no sort of gaps because people experience care, they just want to experience care. The other bit I would think about, I suppose, from everything that we are seeing in terms of the challenges around workforce, and we've been talking about retention of workforce and what support is there for workforce, especially the well-being of staff. I think that's critical, because if we get the strategy and it focuses on well-being for staff, it will help people to remain in the services.
And just briefly for me, so an aspiration I've had for a long time is that it's a sector that people want to come into and that they could have a whole career in, so they could get a mortgage on the back of it, they can raise a family, they can grow, they can move into management, they can move across into other sectors if they wish to. But it would be fantastic to land a workforce strategy that can enable people to come into the sector like we need them to, and that they can stay and flourish and develop and be paid well to reflect the kind of invaluable work they do.
Yeah, I think just building on that point, I think excited 18-year-olds, you know, care needs to be seen as a real aspirational career, and I think I'd like to see people sort of being able to move in and out of the sector and seeing care in the slightly broader sense. So, you know, attributes of that would be a place-based dimension to it, so people could join as an 18-year-old, work in maybe in a care home, but then see themselves as the chief executive of the local NHS trust, or vice versa. You know, I think something about technology. It feels like technology is an important companion piece to care. It's increasingly being used, and I think, you know, my observation is there's some really interesting work going on in social care with technology, but I think in some cases outpacing the NHS actually. So I think, again, a workforce that is technically literate and sees technology as a kind of core part of what it does. A workforce that can kind of really be inspired by the purpose, I think, is another point, and people that are technically competent, because, you know, there's a sense sometimes that caring is just a sort of nice to have, but actually, you know, caring there's a competence to it, to caring, which is also an important component of it. So I think there's a number of attributes, but for me, it's excited 18-year-olds would probably where I'd start.
Just to finish up, some of our work in state of care, we often follow the progress of organisations that were inadequate and how they became good. And one of the things that's really interesting about some of those organisations is how they've worked with local partners to create careers across health and care. So my churlish answer would have been, it would be nice to have a workforce strategy without any branding of either health or care. But I suppose within that, how do you break down the barriers of moving people practically from a health to a care system? I know literally of a handful of examples where they've overcome issues to do with the NHS pension scheme, to do with the way in which people are paid. Because actually, when people come into it, and as excited 18-year-olds, they want a career, and they're looking for a career which, from their perspective, might span both health and care. And it's only we've created a construct which makes that difficult to do. And I think how to remove those barriers in a way that helps local areas and local systems think about what's right for the people that they care for will be ultimately whether it's successful or not. That's, I think, for you, the last question of this section. And then I'll hand to Ian Dilks, who can close this section out. People at home won't hear this.
Thank you. 2 parts, really. One is, I think we can all say that where we see LA funding being an issue, there's a direct equation to lack of quality. So I'm very excited, actually. I'm probably one of the people who are excited in this room about the planned assessment of ICS's working as a whole in areas. And I think funding needs to be part of that. Paying £600 a week for nursing care in this day and age is unacceptable and will lead to bad quality. But the second thing I want to ask, and the last thing I want to ask, is when are we going to hear good news stories? So we were interviewed by Nagarman Chetty last week. Now, and I know this is very important that we're very real. And believe me, I should have said CEO of Bracebridge Care Group, run care homes, and also director of the Outstanding Society. But there's a hell of a lot of good news stories. And I don't see an awful lot of that coming from CQC. So today we're going to bombard the press with all the bad news. And then how do we expect to get 18-year-olds excited when we're telling people how crap the sector is? So I think we need to balance it out, and we need to be telling the story of what's real and what the outcomes that we do achieve. And maybe once a week, CQC put out something really good so that we can actually attract people and keep people in the sector.
Really, really good point. Ian, I'll come to you in a second. One of the things I would say is that when you read the State of Care report, all the cases are positive case studies. So it's I absolutely take your point. I know we've been involved in some work around improvement, which Ian might want to reflect upon as well.
I mean, just to your final point, I mean, once a week we do put out the inspection reports, and there's an awful lot of really good stuff in there. We press release them quite deliberately, but good news doesn't sell, sadly. So I think there is something a challenge for us collectively, I think, to frame. I mean, it's an absolutely the right point. As part of our new inspection approach, one of the things we want to try and do is trying to be a bit more systematic with the way in which we are looking at the vignettes of care, good or bad. But we want to try and look to do a lot more benchmarking and a lot more of those sorts of things in a much more structured way than we've traditionally done. I think we would all acknowledge that one of the challenges of our current methodology is we are producing reports in a long form. It's quite difficult to look across reports and look for themes and so forth. In the new approach, we've got the tools to do that in a more systematic way. But you're absolutely right. This is the point about a degree of balance in what goes on. I mean, it's why I began my session with please acknowledge the good stuff, because it is definitely there, but it doesn't sell, sadly.
Excellent. So I'll invite Ian, our chair, to the stage just to talk through some final reflections. As I said, there is an additional part here. If you felt there's a question you wanted to ask us that you've not been able to do so, just downstairs where you may have got coffee at the start, we're going to try and continue some of those questions in groups, if that's okay. But Ian, over to you.
Okay, thanks very much, Chris. So particularly for those on the video, my name is Ian Dilks. I have the pleasure to chair the board of CQC, a post I took up last year. So thank you very much indeed for coming and your contribution so far. As Chris has said, there will be a second session, and I'll deal with a couple of logistic remarks on that in a few moments. I'm sure, in fact, it was obvious, I think, from listening to the comments that many of the themes in the report have resonated with people in the room. I'd heard although a few good questions and challenging questions of CQC and the way we do it, I didn't hear any disagreement with the points that were made. So they will have resonated with you, but I hope you find the report helpful to pull things together and apply the way we've applied the CQC lens. And a fundamentally important part of that is that everything in here is evidence-based, and that is something we guard very carefully. I'm the chairman of the board. I'm joined by one or two of my non-executive colleagues here today. So this is an important part of the year for us. We've seen the way that this has been shaping up and developing for months, but it's a great opportunity not just to see the way that we've been able to pull it together and land in the media and with stakeholders, but also to hear your feedback on the report. So thank you very much indeed for coming along and giving that. And I say it's really helpful to me and my colleagues to be able to hear it. Now, one of the things that has been mentioned many times today, Ian started in his opening remarks, is that it has been a turbulent year. I haven't actually gone back and seen what's been said over prior years. I'm sure that every year we've said something similar to that, but it has been, I think most people would agree, a particularly difficult year. And the challenges we've talked about already, they're evident. We picked up this phrase or theme of gridlock care last year, and I'm pleased to see that we haven't just dropped that and moved on to a new area. We've recognised that it still there. But there are other challenges now faced by service users as well. And the workforce issues come up particularly, and the reference to the, well, we phrased somewhere, I think, the risk of unfair care. Now, to pick up a comment made from the back, by risk of unfair care, we do not say, we do not imply that unfair care doesn't exist today. There are several examples in the report itself of an unfair situation. What we are saying is that the risks of that get greater, and I thought Ian phrased it very well when he said what we must guard against is unfair care being just embedded in the system. And I won't go off the tangent now, but it's quite interesting looking at the different views on the NHS and the usage of NHS by generation cohort. And I think that tells you something for the way in which the younger people look at the quality of the service available to them. One of the things I thought the State of Care report did pretty well was highlight some things that do work well. You said you don't read about it in the media. We can look again about the way we present it, but I do endorse what Ian said, that we try hard to give good and bad to the media, but guess what? Only one of it gets written up. But we do try very hard, and I think the report does a good job of putting out good practice. And we do that for three reasons. One is, I think it's right to give recognition to the very hard work a lot of people put in and the good outcomes in terms of safety and quality of care that result. I think it sends a message as well that despite all the difficulties, good care and good outcomes are possible. I think that's an important message to everybody so that we don't get into the mindset of saying, oh, it's all too difficult. And the third point I'd call out, and we did touch on it just towards the end, is we do have a role here. Our regulations stand several feet thick, but there is a sentence that says, and by the way, do all of the above in a way that encourages improvement. And I think that's been an increasing focus of the mindset within CQC over the last year or so. Now's not the time to again, go off on a tangent on improvement, but one of the reasons for putting things in the State of Care report is that, as I say, it shows that good care is possible. It might encourage some improvement at a local level, and we want to support improvement in quality of care for individual providers. But it's an opportunity for us also to highlight and showcase some things that have been done to improve care that can be of benefit or picked up by others. Chris has pioneered over the last year some work in an innovation hub to try to make more visible to the care providers at large the good practice that we see in certain areas. And I think you'll be seeing more of that come from us in the next year or so. The publication of this report today, let's be clear, it's significant as it is, but it's not a tome that we then draw a line under and take a big deep breath and do nothing for several months. It is a document that provides a link into the year ahead for us. So there are areas that we've called out, like mental health, like the quality of maternity care, that will still be important. But the third, and perhaps the one I would particularly single out, is the establishment of integrated care systems, our work there and our new powers, also our work rather in relation to assessment of local authorities. This is important. That's why it's come up so many times, both in the questions and the remarks that my colleagues have said. You may not have seen, but I saw Minister Helen Whately commented to the Primary and Community Care Committee yesterday, firstly, that this was one of the biggest changes in healthcare in a very long period of time. I can't remember what she said, generation, but certainly it's a phrase others have used. But she also, with an eye to us, said that was looking to CQC to provide some real insights on what is going on. And I think, as Ian said in his opening remarks, we would expect that when we're here in a year's time, we'll be saying much more about that. That now's not the time to guess what that will be. But I do think it's a fundamentally important role for CQC to comment on how those attempts to bring health and social care together and look at how care is provided at the local level is working out in practice. I don't think we should be under any illusions. I'd be delighted but very surprised if when we come back in a year's time we say everything, guess what, everything is amazing. But I think at least if we can provide some commentary on what's working and what isn't working, that will provide a roadmap to go forward. And picking up on a question that was asked over there, it's not up for us to set the 10-year roadmap per se, but I think we have a major role to play, whatever colour of government we have in a year or so's time, as to what could be done to make these systems work. My, I suppose, final comment I would make is just picking up on an observation that Ian made in his final remarks, that we are very clear that the opportunities presented by changes, but in particular these new integrated care systems, have got to be grasped to ensure that fair care is something for everybody. We do not want it to become embedded. So what we mean is that care, good care, must be available to everybody based on what they need and not simply what they can afford, as sadly we are seeing in places today. Now, that was really all I want to say by way of comment on the report. As I say, I hope you found it helpful, but I would also just like to thank on behalf of the non-executive directors on the board, but also you in the room, for the huge amount of work that Ian and his team have put into this. I say I arrived about 18 months ago. I confess I wasn't too familiar with the detail of the State of Care report, but trust me, it is a massive exercise to put it together. It is evidence-based, and that should not be underestimated. We cannot put in there just what we'd like to think or other people like to see. So a lot of work goes into that, and I think that makes it important and almost unique. And secondly, we are independent, and we treasure that carefully. We are independent, we must remain so. So we tell the story as we see it, unencumbered by external influence. However, it is essential, I think, that we are respectful of other people's views. We seek to be a listening organisation, and we do listen to what other people have to say. But at the end of the day, we report it as we see it. So Ian and colleagues, thank you very much indeed. Tremendous piece of work. So this does bring us to the end of the first part. Once again, thank you. I'd like now to invite you to go back downstairs to this meeting room, where most of you would have had coffee beforehand. The incentive for doing so is that there will be more coffee and drinks, I think. But there'll be a different layout, and it's an opportunity for you to speak among yourselves in a slightly more structured way, and for us to gather some rather more detailed feedback on what you think of what is in the State of Care report. Kate will be introducing it there, but if perhaps I could just ask you now to move back down to this meeting room. Thank you very much indeed.